Welcome to AETCM, the emergency medicine channel. Yes, we are back with the other system, that is a neurological emergency. Past two sections we discussed regarding our cardiovascular and then respiratory emergency. From today onwards, we'll begin with the other system, that is a neurological emergency, as I told you earlier. So in this first part, we are going to deal about the neurological assessment. So what is our main focus? Otherwise, what we are going to in the context of neurological examination means, so our main focus is assessing the integration of brain function and then motor response and then sensory response. So this is our main goal. Again, we know nervous system is a vast one. So if you want to perform each and every test means, that is a more difficult one, and that will take the more time consuming one. So even though in ED also we can't perform in hospital ED also we can't perform every test, because as I told, that will take a more time eating one. So even if it is taking that much of time in ED means, what you will say about the pre-hospital? Again, pre-hospital we will get a minimal time only, right? So in mainly our focus based on the life threats. What are the major important life threats only we are going to assess in the pre-hospital setup. So in that context, so assessment format, where we are well known about the assessment format. The first step is a scene sizer. So the all five things. So we have to make sure our safety and then our crew member safety. We have to take personal protective equipment and then mechanism of injury, nature of illness, determine the number of patients, and then we have to consider the additional resources. So mainly in neurological emergency, the person might be in an agitated state, or the person may usage of some illegal drugs. So because of that, some altered mental status or some agitated status will be there. So in that circumstances, you have to make sure your safety, and then in that circumstances, if you are going to encounter that situation means, you have to take the additional responsive person to approach the scene. So that might be a police force or some other force. So you have to take the appropriate force to approach the scene. So that is one of the important thing. So then coming into primary survey. So here you have to follow the general impression or initial 10-second assessment, and then we have to assess the mental status. So general impression is most important one. Why? So how it is playing a pivotal role in that primary survey. So think, so if it is a scenario, so you are approaching a scene, so the entire family in the same home, they are complaining about the headache or blurred vision. So headache, blurred vision. So the entire family, the whole family members is complaining. Those are the symptoms. So what you will think? So in that situation, you can think about there might be a toxic exposure like carbon monoxide exposure. That is one of the thing we can think. And then other general impression, like if the person is looking like a stroke appearance, so CVA like appearance, so face drop and then unable to lift up arm. So those are the some clue factors that will give some ideas regarding what is the person's general appearance or general impression. So second thing, we have to assess the mental status. So for that we are following the AVPU scale. So A in the sense awake and alert, V in the sense the person will respond to the verbal stimuli, P in the sense the person will respond to the pain stimuli, U in the sense unresponsive. So if the person is awake and alert, the first category means the first step. So the person is awake and alert means your second step should be the how the person is responding. So otherwise, whether the person is orient or disorient, that's the second step. So first step, the person is awake and alert. If the person is awake and alert means, then you have to check the orientation. So whether the person is orient with you or disoriented. So disoriented means simply we can know what might be the causes. There may be a hypoxia or hypoglycemia or hypotension. Those are the some causes for the disorientation. So again, if the person is oriented with you means, so orientation will check with an we can ask the person, place, time, even. So that is again A4, A3, A2, A1. So those are things already we discussed. So based on that, he is oriented means the third step is how the responsiveness. So responsiveness means, so again the person is responsive to you know, so how they are reacting, whether if you are asking question either the person is reacting fast or slow response, that responsiveness you have to check. The fourth one is you have to check the speech and language. So here we mentioned language and then speech. Either that is a slurred speech or normal speech, that we have to check. Language also we have to check. So again I'm telling, so first if the person is awake and alert means, then second step you have to check the whether the person is orient or disorient. So the third step, orient, if the person is orient with you means, then you have to check about the responsiveness, either the person is responding faster or slow response. Then you have to check about the speech and then language. So these are the some key factor in the primary survey and then mental status assessment. Then coming into airway and breathing, so there are four major cranial nerves that is performing in the, that is participating in the airway pattern. See, that is the fourth or fifth nerve, trigeminal nerve, or ninth nerve glossopharyngeal, or 10th nerve vagus, and then or 12th nerve hypoglossal nerve. So those are the things that is participating in the airway pattern. See, that is maintaining your tongue in a correct position or normal position, that will prevent the tongue fall back. So like your hypoglossal nerve, that is a motor nerve, right? So that is preventing some, that is acting like a airway patency. So if any problem or if any alteration in this nerve signals, that will cause too much relaxation or constriction of the airway. That is one of the thing assessment we have to keep in mind. And then again intervention wise, if it is indicated, we can go with a supplemental oxygen, like we have to maintain the SpO2 94 to 99 percentage, that is our target. So if it is indicated, you can go with a supplemental oxygen. Second thing, you should not hyperventilate it until unless you are suspecting the intracranial pressure, increased intracranial pressure. Means if you are suspecting the person have increased intracranial pressure, there you can go with an hyperventilation. Until unless you should not do the hyperventilation. So again hyperventilation means what, and then when we have to do means, we told increased intracranial pressure. So the what are the signs, and then when we have to do, so those are the some set of protocol or some set of things are there that we are going to deal with an upcoming presentation. Just remember, so supplemental oxygen whenever needed we can administer. Second thing, hyper ventilation that should be done only in the increased intracranial pressure. So until unless we should not perform. That's keep in mind. In upcoming days we'll discuss in detail. So circulation wise, again establish, we have to establish the large IV port cannula we have to establish, and then we have to use the, if it is indicated, we can go with an IV fluids like normal saline, ringer lactate, that we can go. But for any reason we should not go with an dextrose, a solution containing dextrose. So what are the things we have? The preparation we have like a dextrose water, we have a dextrose NS, DNS we have, and then 25%, 5% dextrose we have, 50% dextrose also we have. So those are the various forms of the dextrose preparation. So why we should not use the dextrose solution in that head injury or increased intracranial pressure cases? So first thing, dextrose is categorized under the isotonic solution. So again IV fluid classification, if you remember, means there we have a three types of fluids, right? Isotonic, hypotonic, hypertonic. So dextrose comes under the classification of isotonic. So once if you injected, once if you infused into the person, then once after metabolization it will become a hypotonic solution. So isotonic to hypotonic solution. So what will happen in hypotonic solution means, the fluid will shift from the extracellular to the intracellular. Clear? So hypotonic means there will be a low osmolality. Because of the low osmolality, the fluid moves from extracellular to the intracellular. So if the fluid moves inside the cell means, what will happen? That will swollen or that will become a edematous. So again already if the person have a increased intracranial pressure means, the fluid again moving inside, the brain is swollen means, furtherly still more intracranial pressure will increase. So that is the context. So that is why we should not use dextrose in the case of head injury or if you are suspecting increased intracranial pressure. That is one concept. And then we have to correct hypotension with appropriate IV fluids and then vasopressors if needed. We have to perform the ECG monitoring. So disability, this is the most important part. So we have to perform the mini neurological scale. So that include the 5 major components. Mini neurological scale, first one AVPU, your mental status. Second one your GCS. Third one we have to perform the Berla pupillary assessment. Fourth one you have to check the muscle strength. Fifth one you have to perform the focal neurological examination. So these are the 5 components that includes the mini neurological scale. So the first component is a AVPU scale, so already we discussed, and then second component is a Glasgow Coma scale. So again this also we are well familiar with that. So 3 components will be there: eye, verbal, motor. So eye for 4 score, verbal for 5 score, motor for 6 scores. So eye, you can see that if the person is spontaneously open the eyes means that you can give the 4 score. 3 scores means if the person is responding because of your voice or because of your call for means, if the person is opening his eyes means you can give for the 3 score, 2 score for 2 pain, 1 score for no response. So 2 pain, that is also most important. Where we have to pain, where we have to elicit the pain, that is most important. So 2 areas you can elicit the pain. First one, over the nail bed. So like this you have to take your index finger and then between the index finger, thumb finger, you have to place the one pen and then you have to take the person's finger, nail bed. So you have to give a gentle press. You should not harm. You should you have to give the gentle press over the nail bed. So in that time you have to place your pen in a parallel manner. So you have to give a press at least 10 seconds. That is most important. So this is the one way of to elicit pain. Second way, you can press over the supraorbital fossa. There also you can elicit the pain. So 2 major areas you can elicit the pain. The one major important thing, so if you are performing in the nail bit means, so if the person have a intact spine response, otherwise intact spinal pathway means the person will respond to this one. So again the person will respond to the nail bed response. So here that supraorbital fossa, there is no need of intact spinal nerve root because it directly connected with your brain. So sensory response easily they will get back. But if the person have any spine injury, if you are suspecting any spine injury means, thereby if you are performing in a nail bed means, thereby you can assess the integrity of the spinal cord also you can assess. So this is about the I, verbal, I. So again coming into verbal, so we know oriented, confused. 3 means inappropriate word, 2 means incomprehensible sound, 1 means no response. So motor response wise, so 6 means obeying commands, move to localized pain. So 5 means move to localized pain. So there how we have to give a pain. So if considering, so you have to give a pain over the uninjured or unaffected arm. So for example, if the person if the person have an uninjured part of right arm, right forearm means right upper limb, so there you have to give a punch or pinch over the supraclavicular area. Otherwise you can tell the muscle name trapezius muscle, there you have to give a pinch. So if the person move to localized pain, so move to localized pain means while giving a pinch, if you are giving right side over the pinch means with the left hand the person will prevent the stimulation. That is the normal response. If the person is doing the normal response, that will comes under the category of 5. So again I am repeating. So if you are giving a pinch over the trapezius, right side trapezius muscle. So if the person you with the left hand, if the person is preventing the stimulation means, that is the move to localized pain. That is the normal response. 4 in the sense flex to withdraw from the pain. So if you are eliciting pain over the right trapezius muscle, the person is flexing the right arm. So that is the flex to withdraw from pain. So they are flexing the same arm or same hand. So third one is a abnormal flexion, abnormal extension. Second one, one is a no response. So abnormal flexion means how it will be. So this imaging that how the person will be in a abnormal flexion. So other name for the abnormal flexion is a decorticate posturing or decorticate position. So how the person will, so the by the seeing the picture itself we can describe. So the person will flex the entire arm and then forearm, and then they will flex the wrist towards the body or towards the midline. They will point towards the toe also. So this is the image of the decorticate or abnormal flexion. So what will happen in the abnormal extension? So they will extend out their arms outside the body. So there towards the body, here outside the body, so extension. But the major important thing is that they will pronate their forearm, or they will flex their forearm, they will flex their wrist also. See here also they will point out the toes. So first thing, abnormal flexion means they will flex entire arm, forearm, wrist towards the body, and then abnormal extension means away from the body or away from the midline. So abnormal flexion, that indicates direct damage in the direct below the cerebral hemisphere, and then again your decerebrate or abnormal extension, that is indicate problem in the diencephalon or pons or midbrain, or that is we can collectively known as a brainstem. There will be a problem in the brainstem or nearby the brainstem. This is the abnormal flexion and then extension. So and then again we told Berla pupils are equal, round, reactive to light, and then accommodation, that also we have to assess. If the person have a GRB is also one of the major factor. We have to check for the glucose level. If it is less than 60 milligram per deciliter, again hypoglycemia means, so this is the protocol based on the American Diabetic Association we have to follow. If the person is having a intact patent airway, can able to swallow, means you can give the oral glucose. Or if the person is unresponsive, not able to swallow, means then you can go with your dextrose solutions. Like, so again if it is a head injury means you have to take a standard precaution, and then you have to treat the patient. And then hyperglycemia can increase the morbidity of the patient who had a stroke, so that also we have to consider. So exposure wise, again temperature monitoring should be there. If it is a hypothermia or hyperthermia, based on that we have to manage. So transport decision, once after your primary survey completion, you have to think about whether the person is stable or unstable. If any life threat is there, if any needed for the immediate transport, that also you have to consider. Again, that mode of transport also playing a major crucial role, because if the person have a ischemic stroke or we can't identify whether the ischemic or hemorrhagic in the scene. So I am telling, if the person have a stroke or if the person have a status epilepticus, continuous seizure more than 5 minutes, it is not subsiding, means there the center might be in a distance or more than 1 hour to reach out the stroke center or to reach out the multi-specialty hospital. There it is more than 1 hour, means then you can consider about the air transport. So the mode of transport also most important. And then if time permits, we can go for the rapid full body scan or secondary assessment or head to toe assessment, that we can perform. So if time permits, again, but here we are going to discuss the whole format. If time permits, we can perform all things until unless the primary survey you can stop it out, and then while transport you can do the full body scan, and then you can give a handover to the definitive care. So the followed by the your primary survey transport decision. If you have time, you are performing the history taking. This all sample history we know, and then we are going with the systemic assessment, that is the secondary assessment, head to toe assessment. So main thing in head and face, you have to look for the face, and then you have to look for the eyes. So here face wise, symmetry of the face, that you have to check. If any facial drop is there, means that is indicating or CVA or stroke. So again you have to check for the eyes. So if any dropping or sagging of the eyelids is there, means that indicating the Bell's palsy or stroke. So the coming into the next part is a hallucination or delusion. What is meant by hallucination and delusion? So this is coming under the common reality. So hallucination means that is a sensory stimulation that can't be verified by others. Means the person will smell something, or the person will hear something, or the person will see something. So that, but really that not reality that not exist, or the person, it can't be verified by the others. That is the statement. So I think it may clear. So if the person will hear some abnormal sounds, or the person will smell something, but in reality that not exist. It won't be there in reality, but the person have a that much of problem in their sensory stimulation, that is a hallucination. So in delusion wise, that is related with an thoughts and ideas. They may think they can fly, or they may think like they are the captain of the Indian army. It's like that. It is somewhat related with their thought process or idea. This is coming under the common reality. So what is the major disadvantage, or what is the major challenge in the your hallucination and delusion is that they will once the disease gets, or once this problem get worsen means, they will move away, they will far move away from the common reality. So for them it is more difficult to deal with them, uh, even in a pre-hospital or in hospital also, that is more difficult to deal them. So in these cases, they have fear, anger, helplessness. These are the characteristic for the or this psychosis or your hallucination or delusion peoples. So while handling these type of peoples, we have to make sure one-to-one contact. So one person have to communicate with that affected person. First one, second one, always you have to with be a one caretaker or with their family members, that also you have to make sure. And then that is called scene safety. That's our safety should be major important. Third one is we while the time of assessment, we have to give the clear and then simple commands that we have to perform. Fourth one, we have to decrease the stimulation. We should not again prompt that what they are thinking or what they are smelling, that we should not prompt. We have to decrease the stimulation as much as possible, and then we have to try to redirect from the focus. That is also one of the major consideration in the dealing the hallucination and then delusion part. So in then coming into corneal reflex is one of the protective reflex, like our cuff and then your gag reflex. This is one of the protective reflex. It's easy to assess. Just to tap or tap between the eyes. If the person is twitching or blinking means, then you can think about the person have a corneal reflex, so the person may have a protective reflex. So like cuff and then gag reflex. So the person able to control the airway, or the person able to achieve the patent airway. So if the corneal reflex is absent, so again if the person is not blinking or not twitching means, then you can think about the protective reflex may be absent, so the airway may be in a threat. So this is the one type of assessment. And then sensation part, paresthesia, any numbness is there or not. Vital signs as usual, we have to take it out. So again last part, body movements. This is also rare one. If we have a time permits means we can do. So just for a knowledge we can remember. So hemiparesis, hemiplegia. Paresis means that is a weakness of the one part of the body, or one part of the body is correct, upper and then lower limb. Hemiplegia means, plegia indicates that is a paralysis. So paralysis of the one part of the body, there where it will occur in the case of CVA, it will occur. So again gait, the walking pattern. So some person they will walk a slow manner, scissor like a manner. Those are the some type of walking manner pattern is there. So whether they are maintaining in the normal manner, or some cross like a manner, scissor cross like a manner, that is also one part of the assessment. And then bizarre movement like myoclonus, dystonia, rigidity, tremors. So those are the some type of movements also that also we have to assess. And then cranial nerve assessment, again this also a time taking one, but a simple way, within a 1 minute we can perform. So olfactory, we know that is for the smell. So you can ask the person to close his eyes, and then you can give something to smell. So that way you can assess the olfactory nerve. Optic nerve for the vision, so you can ask the person to close one eyes, and then you can show some pictures or some letters, and then you can ask the person to read or visualize the thing. And then 3, 4 and then 6. This is for the motor nerve. So this is a movement of the eye pupil eyelids. So here you can perform, you have to wave the hand in front of the person like a hutch, like a wave. So you have to wave like a hutch. So from left to right, up to down, and then again right to left, up to down. So like that. Here the person head should be in a neutral position. You have to ask the person to move his eyes alone. So thereby you can assess the oculomotor, trochlear and then abducens. So trigeminal, you can ask the person to clench their jaw or clench their teeth, thereby you can assess the trigeminal nerve. Facial nerve, you can ask the person to puff, like 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 that you can ask the person to puff, and then you can ask the person to raise the eyebrow, and then you can ask the person to smile. That way you can assess the facial. And then hypoglossal, you can ask the person to put out the tongue, and then you can ask the person to move tongue left or right side. So that way you can assess the hypoglossal nerve. Accessory nerves, and then here also you can place your hand over the shoulder, you can ask the person to raise the shoulder. That is also one of the thing. In movement of the head, for head, you can ask, you can give some resistance over the face or head region, you can ask the person to move against the resistance. So thereby you can assess the accessory muscle. And then coming into auditory, if the person is hearing everything, each and every commands they are following means, so their auditory function is okay. And then eighth nerve, ninth nerve is a glossopharyngeal. So here also you can take some type of stick, and then you can touch over the posterior pharyngeal area, thereby you can check the gag reflex, thereby you can check the glossopharyngeal. And then vagus nerve also, so if they are following everything and then their voice is normal, so there is no hoarseness of voice means, then you can check about the vagus nerve is intact, there is no problem in the vagus nerve. So again, vagus nerve, why hoarseness means, vagus nerve is a parasympathetic nerve. So if it is get stimulated means, that will constrict the airway, so that will cause the hoarseness of the sound. So if it is not there means, so the vagus nerve it is not affected, then we can think. So final part is a reassessment. So we have to reassess the primary survey. If the any intervention done in between means, that you have to rule out. We have to reassess that statement, and then we have to notify the receiving facility. So what's the case you received, and then what are the assessment you done while the time of primary survey, or what are the initial impression you make in the scene, that you have to convey to the definitive care peoples. Here the timing is most important, like if it is a stroke cases means, the initial onset of time, so when the symptom onset, when the person was appeared normal state, symptom free state, that is also most important, that you have to write it down. And that while the time collecting the history itself, you can ask for the details, and then you can share to the definitive care. If it is a seizure means, how's the activity, whether that is the clonic activity or clonic tonic or myoclonic or atonic, so that's activity you have to mention. Patient experience or noticed any aura spaces there or not, aura, ictal, post ictal, those are the some stages, right, that you have to, if any noticed means, that you have to inform. Whether that is a status epilepticus, that also you have to inform. So these are the various format, this is a various format for the neurological examination. Hope you understood something. So do your best. Shalom.